You guys are a very astute class, probably one of the smarter senior classes that I've seen in a while. So we'll see how that pans out with the test. But this was a great question was brought up. So this is a brand new question, and I try and vet that a little bit here. Somebody brought up a good point, and then I ran it through my colleagues as well, and I gave you guys the wrong answer. So is this person a candidate for thrombolysis? No, because they're out of their window, which means permissive hypertension. Yes, there you go, which means no lowering of blood pressure when we give an aspirin. B. Does that clarify everything for everybody? Probably you were like, what the hell was he talking about yesterday? So the answer is B, permissive hypertension, and the only thing we can give for that is aspirin. Make sense? We're going to clarify that with everyone. I came in here yesterday, I didn't realize, well, I knew it was a holiday, but sometimes we push through holidays for ICAP. Like we're the only program that's open and running, and everything else is shut down. So before I start up here, do I have any questions on seizures right now? So somebody did bring up, and I know neurology probably taught you guys a little bit of different things, but epilepsy means there's no known reversible cause. That's what epilepsy is, so we just treat it. Typically prophylactically, meaning abortive therapy, preventing the seizures from happening. But if it's a reversible cause, then it's not epilepsy. That's just a known seizure that likely turns into status epilepticus. That's when things get hairy. So start here at diagnosis. By the way, we'll see how timeline works out, but we will try and get through syncope today, and we'll see how that works out. Either time or finish up syncope. We'll see how fast this goes. So diagnosis. Again, I want you to just pay attention. These are your differentiating type of symptoms that you're looking for. They give you a much better idea that this is a seizure and not some mimicker. So, should be quick. It just happens. It's not like a slow ramp up to it. And then it terminates right away. Hopefully within 60 to 90 seconds, like I said. People cannot recall. They don't even know it happened. They're like, do you know what happened? You seized. No, I didn't, until you show them the video. They're like, holy cow. They cannot recall this. Complete amnesia from the event. So, and we have these purposeless movements or behavior, and then that post-ictal. So these people are wiped out. They're just tired. They want to go to sleep. So it just gives you a good idea. If it's something else, so typically like a syncope, aka fainting or passing out, those usually have prodromal, meaning there's some onset. Whether they have tunnel vision, they get sweaty, diaphoretic. The same as lightheaded, can get nauseous. What we get concerned about, we get a little bit more of this. The other term is called pure syncope, which means it's a cardiac cause. Those are the ones you have to be worried about. So, occurs suddenly without warning. Grandpa's sitting at dinner, and the next thing you know, his face is in the mashed potatoes. He didn't know what's going to happen, anything. That's very concerning. That's a cardiac cause until proven otherwise. Even with those, you can get a little mixed picture where they can have incontinence and maybe this real quick tonic-clonic type activity when they pass out, not to be confused with a seizure. And no post-ictal period. No confusion, no amnesia. Pretty much sure, did I just pass out? Pseudo-seizures. Anybody ever seen somebody with pseudo-seizures? Quick face to your story. I'm in my neurology rotation. This guy is just twitching away, but he's looking at us, and he's hooked up to the EEG. Now it's day one, so I don't know anything about an EEG. The neurologist says, what do you think of that? I was like, I don't know, looks normal. He's like, good. I was like, oof, 50-50. This kid's twitching away. Takes him off. Says, go to the waiting room. Hallway. And he goes, watch this. He walks over to the phone, calls the guy's cell phone. He's in the waiting room, stops twitching, picks up his phone, and he looks over at us. And then, it's ridiculous. Did that guy follow me to my first duty station? Yes, he did. Walks into the TMC, this guy seizing. Luckily, we had a psychiatric nurse practitioner. He's like, give me some lorazepam. And I just looked at him, I said, he's bullshitting him out. I left and let him deal with it. So, yes, that is a bullshit flag. Now, this being said, psychogenic in nature. So, typically these people have other underlying psychiatric diseases. There's all this list right there: conversion disorder, panic disorder, so malingering, Munchausen. So they're a product of that environment, unfortunately. So, but be sure that they're seizing. If you were to hold that person's arm up and drop it on their head, they magically would miss. So that's what I'm saying. They're not going to hurt themselves. If they're a true seizure, when you drop that arm, we'd hit them right in the face. So just be aware of that. So differential diagnosis, pseudo-seizures. Migraine as well. Like we talked about, like that lady was kind of stumbling through her words, the news reporter. But most common migraine are so scotomas. Those are just little spots that are black. You can't see. Not total blindness. So, and then also sometimes with these migraines, we can have that hymenopsia. So usually you can only see the left side or the right side of your vision. So, and also hemiparesis. So usually should not see any active movement disorders. What do we do with these folks? If they are known, well-documented seizure disorder, we do not need to get crazy about that. We get a glucose on them. Again, we want to make sure that it's not hypoglycemia, but they're not hypoglycemic now because they just got done seizing for 5 minutes. And we get that pertinent anticonvulsant level. Again, you're not going to act on that right away, but as long as they return to baseline, not a big concern, but we want to get that anticonvulsant level because what is the number one cause? Medication noncompliance. So whether they're young and they're just missing medications, you want to get an idea of that. Or maybe they need that level because they just need their medication increased to prevent it. Again, these people with known seizure disorders, typically epilepsy. We don't know what caused it, we just know we have to prevent those. Like our gentleman skydiving, 4 years of no seizure, but that significant stressful event of skydiving put him into that. Now, if it's a first-time seizure, is unsure of their history, we're going to kind of do kitchen sink right there. Glucose, basic metabolic panel, lactate, calcium, magnesium, obviously pregnancy test, and then toxicology studies. Again, this was kind of your warm-up question. If you remember that, go back to that. That's your answer right there. Why do we get a lactate? Lactate's probably going to be increased to give us an idea. We'll probably need to give that person fluids to bring that lactate down. Lactate is a marker for what? So, some type of ischemia, so poor oxygen delivery for whatever reason, and somebody seizing up and their muscles twitching for anywhere from 90 seconds to 5 minutes, probably going to be increased. So we need to make sure that we're clearing that. So again, most of those will clear within 30 minutes. We want to make sure you get a lactate on that person. And then there's a lot of things, a lot of places like this, prolactin as well, because that'll be elevated. Gives you a much better idea. If you're not really sure of that history because it wasn't observed, like, oh, did they seize or not, you can get a prolactin. Prolactin right off the bat. Tell you the difference between a true seizure and a pseudo-seizure. The prolactin would not be increased in a pseudo-seizure. A real seizure would be increased, but only for a brief period of time. So if they seized the day before, this is probably a worthless lab test. Worthless. First time ever, CT scan. First time ever, because you want to make sure there's not some underlying structural lesion. Whether that's a barrier aneurysm, whether that's an AVM, whether that's a brain tumor, whatever space occupying structural lesion. I want to make sure that we get that CT scan.
Is there an alternate if it's a pregnant female?
What's up?
Is there an alternate if it's a pregnant female?
Well, I don't worry about CT in the head for pregnancy.
Okay.
If what belly, yes. But for the head, definitely well worth it. And it's the radiation, it's only gonna be for the head. I have no problem CTing a female patient at all. I don't necessarily need a pregnancy test, but I would get one, just to make sure that that's not some underlying thing like eclampsia or whatnot. And then always be concerned, because people don't like sit in a chair or lay down on the floor when they seize. Comes out of nowhere, they're walking around, typically they fall backwards. So we may need to get additional imaging. If I have a seizure and I'm gonna CT somebody's head and I don't know if they fell or not, I'm probably just gonna go ahead and do a CT head and CT for the C-spine. Because C-spine x-rays are terrible, they're worthless. Worthless in my opinion. I'm just gonna go ahead and CT those. Then you wanna make sure that there's no other injuries. Posterior shoulder dislocations, so if there's any inclination, any abnormal exams, just x-ray it for sure. X-ray those things. Like I said, I already jumped ahead there. CT of the C-spine. If they fell and hit their head, I'm worried. I wanna make sure they didn't fracture something. You can fracture any other vertebrae, but you start messing with the C-spine, you have some pretty significant issues. And then again, if you're worried about did they aspirate, let's go ahead and get a chest x-ray. Sometimes we'll have incidental findings. If there's some underlying malignancy that's in the chest, you can pick up on that. And then again, that shoulder radiographs as well, because that's very common posterior shoulder dislocation. Want to go an extra mile for our people if they are febrile and have a seizure, so immunocompromised. If you suspect a subarach, we want to go ahead and get an OP. And if they seize the day before, we're past that window of 6 to 12 hours when that CT scan is most effective in finding concerning pathology, but get that LP to look for any exams of chromia to rule out a subarach. Not usually readily available, but a lot of these folks are going to need an EEG. In the future, if they've returned to baseline, awesome, but if they are still seizing, and we talked about that non-convulsive person had a seizure and now they're in a coma, and it's 30 minutes later and they're just not responsive, we need to make sure that that's not that underlying non-convulsive status epilepticus. So there was a seizure, and we got to get that, especially because if they're comatose and their GCS is less than 8, then we got to tube them. And when we tube somebody, we first give a sedative and then a paralytic. That way, you're not going to be able to tell if they're seizing or not. So that EEG is really going to get your answer on that. So you tube that person, you call neurology and say, come down, I need you to do an EEG. I had to intubate this person. So, and if you don't like the patient, you push paralytic and then sedative. I'm kidding, don't do that. Don't do that, it's horrible. All right, EEG, but usually you're gonna talk neurology, they're gonna eat less stuff. If they bring that patient in, they'll get the EEG done on their timeline. Everybody tracking on that? Very clear, sedative, then paralytic, okay? Sedative, then paralytic. Okay, it's uncomplicated, we do not get too worried about that. Like I said, I don't get too excited unless CPR is in progress or somebody's not breathing. But not much to do. Put this person in recovery position. Make sure their airway is cleared. So you want to have probably suction yank hour right at the bedside for when they finish seizing, just to kind of suction out their mouth. It can be a lot of mucus, saliva, that kind of thing, because they're going to be clenched up the whole time. So usually don't have to give medications for these. Don't have to give medications for these. Then within 5 minutes, if they go over 5 minutes, or we have 2 seizures where they don't return to baseline in between them, we are in status epilepticus. We need to be much, much more aggressive. And I'll break down medications and what types of things that we use. Again, I'm not going to ask you doses. Again, well documented, these people will typically have breakthrough seizures. Not a big deal, they shouldn't be driving if that's an issue. But we make sure those chances of you getting an anticonvulsant level in the ED not very high, but if you are on a ICU rotation or a medical ward, When you're dealing with somebody, just keep in mind, you need to look at those and make sure that their levels are adequate. And then we need to make sure, like, what precipitated this? Do they know what their triggers are? What causes these breakthrough seizures? Are they under a lot of stress? Are they sleep deprived? Have they not been taking their medications? What type of thing is going on? So ask lots of questions. And again, if they are known seizure disorder, they return to baseline. Glucose is fine. You've observed them. They've had no other seizures. You get the anticonvulsant level. It's okay to discharge those people. It's okay to discharge those people. But if there's anything that they're uncontrolled, or you think that there's an actual cause, an underlying medical cause, then we need to bring them into the hospital and get them figured out. We need to bring them in and get them figured out. So, what I talk about, the three things that I said, risk factors that I get more concerned about. So, is there an underlying infection that caused this? Is there an abnormality with electrolytes that I need to correct and bring them in, and probably need serial exams and serial labs to make sure? And then I get concerned about substance withdrawal. Okay, first unprovoked seizure. After we work these people up, so guidelines according to now, I say we do not recommend hospital administration or admission or initiation of a medication as long as the patient comes back to their baseline. But we are going to do labs. So they need to have all these types of things. They have to have normal neurological examination. They can't have any comorbidities, all the diagnostic testing and mental status returns, but we have to make sure we write them. You cannot drive, and I don't recommend any swimming, heavy machinery. You have to be cleared so you can drive, either by your primary care or by a neurologist. Because if there's a bad outcome and you didn't specifically give them paperwork that says you don't drive, and they drive, that's on you. It's going to come back and bite you. Be careful with that. So, usually don't put them on medications from the emergency department. I'm going to let a neurologist or their primary care do that. I'm not going to start somebody on anticonvulsants from there. Consider admitting these other people, these social admits. So if they're annoying, they're handicapped, they can't get in to see a doctor or whatever. So some homeless person off the street, I'm probably going to admit them because it is not going to have good follow-up care. Not going to have good follow-up. And if we can identify that, we need to probably admit them to get that condition figured out. So, and then let that inpatient team determine what they're going to discharge the patient on if they figure out. Hopefully, if it's a reversible cause, they should be able to treat that and they shouldn't need any medication. But if they end up diagnosing them with epilepsy and they can't figure it out, then they should put them out with medication. So again, make sure that these people cannot get themselves in a bad spot. That would be behind the wheel of the vehicle. It's fine if they wreck the vehicle into a tree on themselves, but chances are they cross the lines and take out some nice family in their van, whatever. So, other things, swimming, avoiding that. I would say probably baths are probably out. Probably need to be showering as well. And not messing with tools or being in an area where they could fall off of something from heights. So driving definitely prohibited 100% though. Disposition is going to determine if they have a history of seizures. Again, glucose, level of their anticonvulsant, and they return to baseline, they're good. Significant stuff, uncontrolled, or secondary cause, they need to be admitted. There's your special populations, we'll get into that. Any questions so far before I talk special populations? Somebody brought up a great question yesterday. I know there's some neurology teaches some stuff. But again, epilepsy means we don't have a cause for it. We do not have a cause. I know that probably know what Major Rogers talked to you about, but this is going to be directly from Titnally. Now, Titnally is an interesting thing because if you read it, some of the chapters will contradict each other because each chapter is written by usually a group of 4 or 5 physicians. So they may have their opinion and their take on this, so there are some contraindications, but I've not had any issues with that with this particular block. So Not that you're gonna see a lot of this, but we get really concerned in our HIV population. And you do have to ask people about that. And there are times, yeah, I've had soldiers in my unit that HIV positive. And you wanna be real careful about that. You don't talk about soldiers' issues with anybody but providers. Be very careful what you talk to your command about. Because if you tell them everything about soldiers that you see in your clinic, I pretty much tell them, yeah, so-and-so's deployable, so-and-so's not deployable. That's about all I need to see. All I need to know is what I run in the profile. None of their business, because if I go putting everybody's business out, do you think soldiers can come in and be honest with you? Their credibility's in the toilet. And everyone that's gonna come in and see you is gonna lie. Like, he's just gonna tell chain of command, or she's gonna tell chain of command. Be very careful with that, as far as HIPAA and whatnot. Sidebar. So anyway, all these other types of things, because somebody's immunocompromised with HIV, it just opens the door. It's like having a kid that's not vaccinated. You just went from like, here's your target to this big. So we have all these different types of things that can happen. Very extensive investigation with an HIV positive person that comes in after a seizure. So we're gonna do a CT scan. If you have an HIV positive person, you're pretty much putting a needle in their back for whatever they're coming in for, especially if they're febrile, they had a history of a seizure. We gotta figure out what's going on there. So any number of these types of things that are only gonna show up based on CT scan and whatnot. So, and if we don't find anything on CT, they probably need to get a CT with contrast. So this person's pretty much not going home. You're gonna take this person. You gotta get them figured out. Why did they seize? It's not normal to have somebody seize if they're HIV positive. Very concerning. The other patient population worry about is pregnancy. So they say that most seizures in pregnancy are they're not their first time. So maybe that person seized at night and didn't even know it and just woke up the next morning, went on their merry way. So I want to make sure that these people, if they have a seizure, they need to be evaluated by an OB doctor. Probably admitted to OB to get it figured out. It's not normal. So if they're beyond 20 weeks, yep.
So talking about that, where a woman seizes during pregnancy is probably not her first one. Is there like, this is gonna sound like an expiration date where you could have an allergy to something as a kid and then not be allergic to it as an adult? Could you have had a seizure as a child and then never have one until you're an adult and then suddenly start having them again, or is there not that kind of?
There's no prognosis on that, honestly. I mean, it's like allergies. Some people get worse with them, and some people outgrow them. It's seizures are no different. I mean, people can outgrow them. They can get worse and more consistent. I'd say as a whole, those seizures typically happen more often as people go on. So again, just make sure you're ruling out this eclampsia. That's probably the biggest thing, biggest cause for pregnant women now. That's 20 weeks and beyond. So, and that's just a combination where they have high blood pressure, edema, and then proteinuria, whereas that edema is typically going to be in the legs. So we're going to see majority of that. And that's eclampsia. What do we reach for? Mag sulfate, right there. Mag sulfate. Pregnant, seizing, mag sulfate. They don't reach for any other benzos or any other stuff. Now we'll get, if it turns into status, yeah, we could potentially go more, but mag sulfate is what we reach for. If I had a pregnant patient that's seizing, I would use mag sulfate. You're welcome. All right, then we have all these other types of things, alcohol abuse. So that's why we have the CEWA protocol. Anybody heard of that? So you can put CEWA protocol if you have somebody come in that's known alcoholic or you suspect that. I do not want to deal with somebody who's having a withdrawal seizure. So that's why we will preload them. Prophylactically, I will give them usually diazepam for these. But benzos are the way to go. I said, chill these people out. So CEWA protocol, they start having hypertension, they start getting sweaty, they start having DTs. That's just to let the nurse know, hey, I gotta keep an eye on this guy. So, or lady. So, unfortunately, large doses, don't hold back these folks. Get them on their prophylactically and then hit them with the higher doses as well. Now this is where it gets serious. So we talked about seizures, not so not so crazy concerning. Like I said, most of them are self-limiting, 60 to 90 seconds, over 5 seconds, or 2 seizures with no return to baseline, right here. Now, this status epilepticus does not matter if you have known seizure disorder or it's a first-time seizure. Does not matter. Does not matter. Causes, right there, there's your number one. That person's probably not been taking their medication like they're supposed to. But we have all those other things. Like I said, what's concerning for me, I worry about CNS infections. I worry about metabolic abnormalities. I worry about alcohol, drug intoxication. Those are the 3 ones that just become a little bit more of an emergency to me. Doesn't mean the other ones aren't serious, but those are the ones that are concerning. If we hit 5 minutes, because everybody hits their timer right when the seizure starts, right? No, but you're gonna have an idea of that 5 minutes, not likely that that seizure is going to terminate on its own. So that gets really concerning. If we're going past that 5 minutes, less likely the meds are gonna help, and more likely that they are going to have brain damage from it, more likely. This becomes a very serious, this is not an HPI patient anymore, this is a action patient. You're in there actively trying to take care of it. At the same time that you're trying to treat it, you're also trying to figure out what the cause is. It's a tough thing, so you're multitasking, definitely multitasking. Again, we talked about that non-convulsive status epilepticus. That's somebody who had a seizure and now they're comatose. But they can also have some fluctuating system symptoms. So again, we need to get that EEG. That's where you call neurology, tell them to come down and get an EEG. Well, they're going to want to talk to me. Cool, they can come down and talk to me in the emergency department. Come and talk to me in the emergency department. Sometimes subtle findings, but again, that very long post-ictal period, if even that. So fluctuations in mental status. A little bit more difficult as people get older. That's why I always like to have some caregiver, spouse, child, son, daughter, whatever, that can come there where I can say, hey, are they always like this? And they're like, no, they're never like this. And they're like, oh boy, maybe I should be concerned that this is non-convulsive status epilepticus. All right, the visual folks right here. I know that's not super huge, but this is only for status. So obviously 0 to 5 minutes, that's all just supportive care. We just want to make sure that they're not injuring themselves. Get IV access, get your safety net set, because when they're at 0 to 5 minutes, we're not too worried about it, but the second it crosses that path into 5 minutes. So getting IV access can be difficult, right? If somebody's twitching and thrashing around. Not getting an LP during that period. Good luck with that. But right there, I know a lot of people have heard midazolam. So that's more of an adjunct. What we reach for first is either lorazepam or diazepam. And I'll tell you, most places it's going to be lorazepam as far as the medication of choice. So up to 2 milligrams. So if you listen to Emed Basic, you can listen to about 30 minutes on status epilepticus, and they'll break down. There's a lot more studies that are saying we should reach for midazolam, which we'll get down there. We see that that's in refractory. So, and basically what we've done is we've done a benzo, and then we're going to reach for a phenytoin or levetiracetam, aka Keppra. Once we've tried those 2 medications and it's not stopped, now we're into refractory. And then all those type of medications. So midazolam, propofol, ketamine, phenobarb, and then if we're not getting that under control, we need to be securing that patient's airway, or we're going to run the risk of some pretty significant neuronal damage. Pretty significant. So I like this slide just because it kind of breaks it all down for you. Yes.
So, sir, if you give the lorazepam and the phosphenytoin, like, let's say it's only been 7 minutes, would they immediately be refractory since you tried?
Once you've used 2 medications, 2 classes. So whether that's any, don't get me wrong, your MTF may say, neurology wants us using diazepam. Cool. And obviously this is all given IV. We're not, none of this is oral. No. Diazepam is a great medication, also known as Valium. Great medication for somebody with severe muscle spasms. But be real careful, don't give a lot of it out unless you want to get somebody addicted. Careful with that. So, once we know we're in status, we've passed that 5 minutes where they've had 2 seizures not returning to baseline. We want to get IV access. Yeah, probably somebody's going to have to hold down that arm and get her from twitching so we can actually get the IV. You guys will do IV lab at some point. It's a good time. And we'll see who in the class. Bagels. Always at least one. It's a good time. So, starting normal saline, no glucose right at the bat, no glucose right at the bat. And then getting that safety net in place. That's where my pucker goes down. I feel a lot better if I have IV access. I got somebody hooked up and give them every little bit that I can. That way, if things do go past that 5 minute, we've already got IV access. I can start pushing meds and get that thing under control. So, if it's a established status epilepticus, so let's say you've gone into status and you push midazolam and they're not getting out of it, we need to think probably about 10 minutes. We should be probably placing a tube. So, paralytic. So they recommend succinylcholine, not rocuronium. Any idea why? Duration of action, absolutely. So the reason why is if neurology wants to come down and you push rock, they're going to be paralyzed for like an hour. They can't do any neuro exam whatsoever. So succinylcholine. Contraindications for succinylcholine? Trauma, burns, mostly because that deals with hyperkalemia. Okay, want to be careful with that. Succinylcholine. But and then after we decided if we're tubing a patient, we should have neurology coming down to do an EEG. We should have them come down to do an EEG. There's your initial laboratories. Metabolic panel, yeah, it's a basic metabolic panel. Usually you have to order a calcium and a magnesium separately. That's why that's written like that. And then get an idea of a lactate. And then based upon your patient, HEG, anticonvulsant levels. That top screen, that anticonvulsant level, that's going to be for the inpatient team. You're not going to make any clinical decisions on that. If they're in the emergency department long enough that you can get those results back, and then you consider like what other tox stuff do you want to get. Maybe they overdose on something, so we always get a aspirin and Tylenol as well on top of that. So glucose, if we need to, make sure the patient's not hyperthermic, passive cooling, and then do we need to monitor eyes and nose? Sure. Sometimes we place that urinary catheter to monitor urine output, but also because they're going to have incontinence. We just don't want to make a mess. And then NG2 potentially if they end up vomiting. NG2. So, toxic ingestion, you're going to pick up the phone and you're going to call poison control. And hopefully you have an idea, maybe they found a pill bottle, you just go back and look at the patient's medications to see what they had access to. My very first intubation was a 14-year-old girl, TCA overdose. So that's what she was on for her migraine headaches. She survived, but it was a bad deal. So Valentine's Day is tough on a 14-year-old female. Anyway, so make sure it's normal to have a little bit of a leukocytosis. That's marginalized, stress-induced leukocytosis. It's going to be slightly elevated, maybe 14, 15,000. What's other things that can cause leukocytosis? Infection, yeah. Pregnancy. Steroid use. Just give you an idea, so you can just go jumping on that. You need to have a line in the sand where it's like, that's just stress-induced versus that's serious. We need to be worried about that. And then again, x-rays once the seizure is abated, make sure we're looking at anything else that might be going on. Benzos. So lorazepam, right there. That's what we're gonna reach for. Now look, it's slower onset for lorazepam, but the thing is, look at how long that duration is. 12 to 24 hours. That's why we typically reach for that. Okay, so duration of action, a little bit slower onset, but it's gonna last a lot longer. Again, some places do say, let's go for lorazepam, or that's all you have. Great, but lorazepam is gonna be our go-to, number one. Number one, right there. More effective than phenytoin. We're essentially loading the patient on lorazepam and then reaching for other things. Again, that's the TIPNALI, that chart is what TIPNALI says, but your MTF should have, hey, here's how we handle status in this hospital. And everybody's supposed to follow that. A lot of times we even have a little card for you to wear on the back of your badge, along with like how to deal with the fire, crazy, and then what all the color codes mean. Interesting stuff. Just like, you know, for some of you that have worked in a hospital, not trying to be facetious, but there's a lot of folks that had never worked in a hospital before. And it's just, every hospital has their own protocols for how to deal with things. If we do reach for the second line, pretty sweet that they both come out to 20. Again, I'm not gonna ask you that. But cool thing is with phosphatidylcholine, we can give that IM. And we consider giving these IM if we cannot get IV access. These medications are given IM. Medications are given IM. And levetiracetam. It took me a while practicing that word before I can say it right now. It means a lot when you say things properly. Just physicians will let you know if you're not saying it properly. Again, luckily it's around 20 for the dose on that. So, not 100% approved by FDA, but this is something else we're gonna reach for. So obviously, this potentially, I would never go for this, but a lot of places use Keppra as a prophylactic medication. So if somebody has a subdural, they'll put them on Keppra because the head trauma, older people are at higher risk to go have seizure from the trauma. Again, here's your refractory 2 anti-uplifting agents. This is scary because status can go on for over an hour. Somebody's body's going to be destroyed. Lactate's going to be huge. Then we talked about all those other medications. I'm not going to get so far into the weeds that you guys are. I don't think that I have any refractory status uplifters, but I'll double check on that. So just be aware if somebody sees them that long, they're probably going to go hypotense. And how do we take care of hypotension? Yes, we can give them fluids. That's great. But if they're continue to be hypotense, refractory hypotension, then we need to reach for vasopressors. We'll talk a little bit more about vasopressors when we get into sepsis lecture. Talk more about that there. They do like propofol. It's a great medication. Just be leery, people that are allergic to eggs. So, not use propofol. So, very short half-life. What does that mean? You start it, works great. You stop it, wears off very quickly. Wears off very quickly. So, just be aware the higher the doses, we're going to have side effect that can cause hypotension. Don't ever give somebody morphine if they're hypotense, unless you really, really, really want to put them in shock. Histamine response blows the vessels wide open. You know, watch somebody tank real quick. Be careful with high dose propofol too. Midazolam, infusible. Just be aware that can accumulate in the peripheral tissues and end up causing some renal insufficiency if we're giving that high dose. So what I'm saying is just be aware if you have a patient that has chronic kidney disease, already has some underlying renal insufficiency, renal disease. I need to take it easy with that. And then barbiturates, third line. Never even got to that before. So just breaks that down. Real quick, just be aware with barbiturates, it's like a narcotic, it's gonna cause respiratory depression and hypotension. But there's your current recommendations, propofol, midazolam, and then barbiturates. It's a bad day if you haven't get all the way to that last one, bad day. Another one's getting more and more popularity, is just across the board. Ketamine. Ketamine's getting a lot of notoriety, being used a lot more in the military. So, not FDA approved, but there's a lot of studies that are showing it's very, very useful. If you ever give somebody ketamine and they're lucid, please tell them what it's going to do to them. Because I had a guy that tried malleolar fracture, they gave him ketamine 3 times, he thought he died every time. They didn't tell him what it did. It's a disassociate. It'll put you on a whole other freaking planet. Okay, again, we need to intubate this patient. So what do you think we're using for sedative? So I say probably go with propofol. Stay with propofol. There's other types of things that you can go with, but the point is succinylcholine. Succinylcholine. We talked about this. Rocuronium. Don't mess with that one. Don't mess with that one. But the only thing that's nice about rocuronium, it does have an antidote, a reversal agent. Succinylcholine. We have to. And then obviously we're going to admit these patients. All right, let's do check on learning and then I'll put you guys on a break. Sound good? Well, I never talked about Lamictal, so that's out. Never talked about Benzlophos, that's out. So, A, okay, diazepam or lorazepam, but out of those choices, for the reason that there's a lot of places that, like with alcohol withdrawal or any substance withdrawal, they prefer diazepam. I'm not sure exactly why. I mean, we know it's quicker onset, but it doesn't last as long. It's just, sure the exact number I should ask them why do we go with this. But either of those, just no benzo. I know everybody's thinking like, man, these questions aren't all that hard, but it's different when you're sitting down at a test. It's like watching somebody go through an oral board. You're like, man, I would crush that until you're in the hot seat. And the stress will get you. All right. So it's a known seizure disorder. We know they're taking medications. The great Stacy's been taking his medication as prescribed. Okay, that's awesome, but you can't always trust a patient. This is going to be B. Okay? And they return to baseline, pregnant, discharge them, but let's check their glucose, let's observe them, and get a level of that anticonvulsant. Hopefully they're neurologists. They should be seeing a neurologist. We'll follow up on that lab and call them and say, hey, you sure you're taking your medication when you're supposed to? Or maybe I need to bump it a little bit because we're having breakthrough seizures. No, you will not have a single sentence question. Sorry. They're all big boys and girls now. A, change in seizure pattern. You want to make sure, hey, what's different about this seizure today? Some people just like, I have seizures and they just deal with it and they don't come in. But if they come into the hospital, then you got to figure out like, what changed today for you? I ask patients that all the time. I also ask them what their expectation is. I want to make sure I'm on the same sheet so I don't get some nasty gram. later. I said, what made you come in today? What changed? You have seizures all the time. What was different about this one? Be concerned about that. There's some reason they came in. Maybe it's a Monday, maybe they just wanted to get out of work, whatever. Which one did I talk about that I had, they think it's psychogenic in nature? Okay, complex A. That's the one where they're like, it's not a seizure, they're weird. Seizure. So, this guy's having all these repetitive things, he's also having hallucinations. So, good deal. Go ahead and take a 10-minute break and we'll come back in and see.